What if the lab values we often ignore could be the hidden killers in heart failure? Stay tuned to find out how tiny shifts in potassium and sodium change survival. Here is the paper itself. Heart failure, or HF, is the inability of the heart to fill or eject blood efficiently, causing fluid buildup, frequent hospitalizations, and a 5-year survival that rivals many cancers. Before this work, clinicians followed guideline-directed therapies and measured electrolytes mainly to avoid acute arrhythmias. Yet there was no clear evidence on how persistent electrolyte abnormalities affect longer-term outcomes. Biswas and colleagues asked whether patients whose potassium or sodium stayed abnormal throughout hospitalization faced higher 30-day mortality, and whether those lab patterns could be turned into a simple risk score. The authors mined the Mimic Roman IV database, identifying over 30,000 heart failure admissions. They defined clinically significant electrolyte abnormalities as persistent hypo or hyperkalemia or hypo or hypernatremia across all labs during a stay, and compared outcomes to patients with normal electrolytes. The primary endpoints were 30-day readmission and mortality after discharge, allowing the team to see whether electrolyte disturbances influenced short-term survival and healthcare utilization. They used multivariable Cox regression, fine gray subdistribution models to treat death as a competing event for readmission, and propensity score weighting to balance baseline differences between groups. This flow diagram illustrates how the initial Mimic Roman IV heart failure admissions were filtered down to the final analysis set, highlighting the 950 patients with persistent electrolyte abnormalities and the 713 who survived to discharge for post-discharge outcome assessment. After adjusting for key confounders, patients with persistent electrolyte abnormalities faced nearly double the risk of dying within 30 days, an adjusted hazard ratio of 1:93. The forest plot displays 3 adjusted hazard ratios. Readmission risk drops to 0. 29, heart failure-specific readmission to 0. 17, while mortality climbs to 1:93, underscoring the competing risk phenomenon. These Kaplan-Meier curves illustrate that patients with electrolyte abnormalities separate early, experiencing higher mortality while having fewer readmissions over the first month after discharge. The paradox of lower readmission stems from the fact that many patients die before they can be readmitted, and the abnormal group also tended to have shorter lengths of stay, limiting the window for post-discharge events. When examined individually, each electrolyte abnormality independently raised mortality risk, with hyperkalemia showing the strongest association at a hazard ratio of 1:67. The authors built a 5-variable risk score that adds 2 points for any electrolyte abnormality and 1 point each for age over 75, chronic kidney disease, multiple prior admissions, and coronary artery disease. The score modestly discriminates risk with a C statistic of 0.593. This figure visualizes the separate mortality hazards for hypokalemia, hyperkalemia, hyponatremia, and hypernatremia, reinforcing that each abnormality independently worsens survival. In practice, clinicians should treat persistent electrolyte derangements as red flags for mortality, not assume lower readmission means lower risk, and consider using the 5-point score to identify patients who need intensified follow-up. The authors acknowledge that, being observational, the study cannot establish that correcting electrolytes will improve survival, and unmeasured factors may still bias the results. Also, they lacked post-discharge electrolyte data. Future work should include randomized trials to see if targeted electrolyte management reduces mortality, expand monitoring into the outpatient setting, and validate the risk score in other heart failure cohorts. The practical message is clear. Persistent electrolyte disturbances are a warning sign. Incorporate daily labs, apply the simple risk score, and ensure patients understand why staying on their meds matters. Thank you to Biswas and his colleagues for this important work, and to Scientific Reports for publishing it. Their findings help us better protect heart failure patients from hidden electrolyte dangers.